Hello students. So continuing our topic of spinal cord injury, today we are going to see impairments, clinical manifestations because of spinal cord injury. What will be the clinical presentation of the patient when they come to you as a physical therapist after a spinal cord injury. So there are two types of impairment. First of all, for now we are going to discuss only the direct impairments. Indirect impairments and their management will be a different lecture. So we are going to start with direct impairments. We are first seeing spinal shock. So initially, when the patient has undergone a trauma, the most common form RTA, road traffic accident, because of this, the spinal shock will be the first stage. It is believed to result from very abrupt withdrawal of connection between higher centers and spinal cord. Because of the trauma, all this reflexes, all the sensory, all the motor aspects of the spinal cord are completely absent. Yes, it goes into shock because of the trauma. Absence of all reflex activity, flaccidity, and loss of all the sensation and motor function below the level of the lesion may last from several days to several weeks. First indicator to the resolving spinal shock is the positive bulbocavernous reflex. Second, motor sensory impairments, as we discussed, complete or partial loss of muscle function below the level of lesion. Below the level of the lesion, we have talked about spasticity below the level of the lesion, and at the level of the lesion, there will be flaccidity. Depending upon the site of the lesion, there will be sensory impairments also. Impaired or absent sensation below the level of the lesion. Clinical presentation depends on the neurological level, completeness of the lesion, and symmetry of the lesion. Yes, if one side is affected, how much the affected, what is the level of the lesion, and completeness of the lesion. If it is complete disruption of the spinal cord, complete cut, at that time you cannot expect anything but element type of sign and symptoms. Autonomic dysreflexia, an important topic that I would like to discuss today. So it is acute onset of autonomic activity from noxious stimuli below the level of the lesion. So it occurs in lesions above the T6, that is above sympathetic splenic outflow. Following spinal cord injury, the impulses from the vasomotor centers cannot pass to the site of the lesion to counteract the hypotension by vasodilatation. So in general, if I have to teach you, this is the first stimuli. This is the noxious stimuli. It can be anything else also. A pressure sore can also cause such stimuli. When the bladder is full, the spinal cord sends signal. In normal individuals also, it sends signal for the brain. The brain senses the signals, and we have an urge to urinate, to pass the urine, to micturate. So when the bladder is full, the spinal cord transfers the signal. But as we know here, there is injury. The nerve message is blocked. When it is blocked, because of this, there will be blood vessel constriction. Because of the constriction, it will lead to increased blood pressure in that part, which will lead to brain senses increased blood pressure. Because of this, it tells the heart to slow down. That is, it goes for bradykinesia. When the heart goes for bradykinesia, there will be sign and symptoms like nasal stiffness, pounding headache, sweating above the level of the injury, flushing of face and neck. It is an emergency condition. Immediately, the patient should be, first of all, whichever the stimuli is from which the chain of reaction has started should be stopped, or else he or she should be taken to the hospital for medical management. So, what can be the stimuli for such? We have seen bladder distension, second, rectal distension. Third, pressure sore, urinary stones, bladder infection, noxious cutaneous stimuli, kidney malfunctions, urethral or bladder irritation, environmental temperature changes. Uh, it is at times very common for individuals to get bladder infection because there is bladder and bowel dysfunction. Also, we'll be discussing the same indirect impairments. So, because of that, UTI, urinary tract infection, because of the infections, also such stimuli can be felt, and the patient can go for autonomic dysreflexia. What are the symptoms? We talked about hypertension, we have talked about bradykinesia. There will be headache, severe and pounding, profuse sweating, increased spasticity, restlessness, vasoconstriction below the level of the lesion, and vasodilatation above the level of the lesion. Yes, if you see, this blood vessel constriction is below the level of the lesion. To compensate that, brain sends signals for vasodilatation at the above levels. Constricted pupils, nasal congestion, piloerection, and blurred vision because of the decreased heart rate above the level of the lesion. Intervention, it is a medical emergency as discussed. Patient is brought to sitting position. Bladder drainage system should be examined immediately. The first and the foremost thing to be checked is the bladder and the bowel functions. Check for irritating stimuli such as tight clothing, restriction catheters, straps or abdominal binders. If the symptoms do not subside, medical and or nursing assistance should be sought immediately. Yes. Moving to the next part, that is postural hypotension. We have discussed this. Decrease the blood pressure that occurs when assuming an erect or vertical position. When the patient remains in supine position for prolonged period of time, the heart uh, it accommodates accordingly. It pumps less blood, and when the patient assumes sitting position or standing position mainly, the blood pools directly into the legs and the heart is unable to pump enough amount of blood to the brain. Because of that, it leads to hypotension. Frequent with cervical and upper thoracic lesion related problems can be edema of legs, ankle and feet because there is blood pooling. So what is the mechanism? Loss of sympathetic vasoconstriction control and reduced muscle tone leads to peripheral venous and splenic bed pooling. This leads to reduced cerebral blood flow and decreased venous return, which leads to lightheadedness, dizziness, and fainting. And the patient can directly faint and fall on the ground also. So what can be done? So the CVS should be allowed to adapt gradually by a slow progression to the vertical position. He should be vertically positioned. You can see such beds are available in which the patient remains supine line, but this bed can be moved with a motor, and this allows conditioning of the CVS to standing, and then the patient is asked to walk or stand independently without such machine. So vital signs should be monitored continuously when you are asking the patient to stand for the very first time after a prolonged period of bed rest. Vital signs play an important role. You should always check for vital signs. Use of compressive stocking and abdominal binder may help. Compressive stocking in the lower limbs that will allow movement of blood from periphery to the heart. Drugs can also be given. Ephedrine to increase the blood pressure and diuretics to relieve edema of the legs can be used. Coming next to temperature control directly. Why? Because we already know skin is the main organ through which temperature is controlled through the vasoconstriction, vasodilatation in the skin. So control of hypothalamus on cutaneous blood flow is lost. Autonomic dysfunction leads to loss of internal thermoregulatory responses directly. Lose the ability to shiver. Absence of thermoregulatory sweating below the level of the lesion leads to excessive compensatory diaphoresis above the level of the lesion. This is same as it happened in blood pressure during autonomic dysreflexia. There will be sweating below the level of the lesion, excessive sweating, and because of this, there will be excessive retention, that is diaphoresis, above the level of the lesion. Body temperature significantly affected by external environment. Respiratory important, most important part. We have seen it will depend, respiratory function varies considerably depending on the level of the lesion. So we know splenic nerve C3, C4, C5 supplying the diaphragm is at the C3 or C4 level when there is injury, specifically at C4. If there is injury at C3, you already know the patient will be no more because immediately the diaphragm will be paralyzed, and once the diaphragm is paralyzed, the patient cannot breathe, he'll no longer exist. So at the C4, partially the diaphragm will be spared. So more the higher the level of the lesion compared to C4, T1 to T11 and T7 to T12, more will be the higher the level, worse will be the prognosis for the patient considering respiratory impairments. So the level of respiratory impairment is directly related to the lesion level as we have discussed. Residual respiratory muscle function. Third, additional trauma sustained at the time of the injury. And fourth, premorbid respiratory status. So second, residual respiratory muscle function. So whichever muscles are remaining, are they functional? What amount of strength do they have? That also depends the impairment, respiratory impairment. Third, additional trauma sustained at the time of the injury. What additional trauma? For example, it was RTA. So not only does the level of the lesion of the spinal cord matter, also if there was any injury directly to the ribs or the lungs, that also plays an important role. And last, premorbid respiratory status. So before this trauma, before this condition of spinal cord injury, was there any pathology? Was the patient having any asthma or COPD or any other disease for respiratory condition? Pulmonary complication, higher mortality during early stage of tetraplegia. Also, higher the lesion, greater the loss of respiratory function. We have seen that more is the respiratory impairment. Paralysis of external intercostal muscles leads to decreased chest expansion and lower inspiratory volumes. Higher level of lesion leads to increased involvement of accessory muscle, that is sternocleidomastoids, trapezius, pectoralis minor, and serratus anterior. Accessory muscles also play an important role when chief muscles are not working. Loss of abdominals and internal intercostals leads to significant decrease in expiratory efficiency. As you know, these are accessory muscles for expiration. The lowered position of the diaphragm and the lack of abdominal pressure to move the diaphragm up leads to decrease in the effectiveness of cuff and decrease expiratory reserve volume. As you know, for cuffing, abdominals are the prime muscles which work to expectorate all the mass during cuffing, and altered breathing pattern leads to permanent postural changes. After this, directly we have talked about spasticity. Results from release of intact reflex arcs from CNS control is characterized by hypertonicity, hypertonic, hyperactive, stretch reflex, and clonus. We have already discussed about assessment of how to assess a reflex, how to check for reflection, and what is clonus. Gradual increase in spasticity for first 6 months. Plateau reached in around 1 year. Spasticity increased by multiple internal external stimuli. So in spinal cord, initially there will be flaccidity at the level of the lesion. Below the level of the lesion, there will be spasticity. The higher, the better the spasticity increases, it is good. So the time that we have as a physical therapist to recover this is around 1 year. Yes. So it gradually increases in first 6 months and plateaus by 1 year. So by 1 year, maximum try should be made to increase the spasticity and make it more functional. Spasticity is not always beneficial as we have discussed. So some spasticity may assist in functional activities. Strong spasticity interferes with function. For example, excessive spasticity in wrist flexors does not allow grasping or manipulating any object with the hand, affected side. So excessive spasticity is not needed. It should be functional. So drug used for excessive spasticity is like diazepam, baclofen, dantrolene sodium. You are already aware of these. Peripheral nerve blocks or intrathecal injections can also be given to reduce the spasticity if that is excessive. Orthopedic surgical procedures, myotomy, neurotomy, tenotomy can be done, and neurosurgical procedure like rhizotomy and myelotomy can be performed to decrease spasticity. Bladder dysfunction, bladder and bowel play a very important role. So UTIs are most frequent medical complications. We already discussed autonomic dysreflexia. Stage of spinal shock. At the stage of spinal shock, it will be a flaccid bladder. Treatment focused on effective system of drainage and prevention of urinary retention and infection is a prime goal. So T11, T12 being the bowel and bladder centers. So any injury at that level will lead to spastic or flaccid bladder. So primary goal for bladder training is patient free of catheter if it remains so, and control bladder functions as much as possible. So there are two types of bladder we talked, spastic and flaccid. Spastic bladder is using micturition reflexes and trigger stimulus to establish planned reflex voiding. So micturition reflex can be used and directly as there is tone in the excessive tone in the bladder, that tone can be used to empty the bladder. Flaccid bladder, intermittent catheterization from externally, intermittent catheterization from time to time should be given to patients to relieve flaccid bladder as there is no tone in the bladder. Also, with bowel dysfunction, level of the lesion at or above the T11 to T12 is spastic bowel. At the lesion below T12 is flaccid bladder. Same across for bladder. Bowel training program for spastic bowel, that is regular scheduling evacuation, usually every other day, once in 2 days. Responsible to a combination of laxatives, stool softener, and suppositories. Digital stimulation can be used to initiate a planned reflex bowel evacuation. Yes, so a planned treatment, initially the patient will not respond to these treatments, but with time it will be regular and then it will become a part of the schedules in ADLs to go through this training. And last, that is bowel training for flaccid bowel. So daily evacuation necessary to keep the rectum clean of feces and prevent incontinence. Response to medication less effective than with spastic bowel. Non-responsive of digital stimulation and manual removal of stool from the rectum may be required. So the main difference between spastic and flaccid you all are already aware. Flaccid is no tone or hypotonic, completely no tone, that is flaccid, and spastic is hypertonic. So hypertonic is always better compared to flaccid, because for flaccid you have very limited choice. You have to manually remove it either by manual removal of stool. There also medication will not be effective, while in spastic medication will be effective and it will be part of the daily routine then. So this was it about direct impairments. I'm keeping this video till here so that we do not extend the length of the video. So hope you got all of this. We have already discussed this in your fifth semester. It will be a kind of revision to you. So yes, this is it. Take care. Be safe. We'll be having lecture on this tomorrow. Yeah, be safe.